And I label the structure B, here C, here D, and then this one obviously here, which is E, goes continuously here, it's E, and then this one F, what would you call that? What's A? Cystic duct. How about B? Common hepatic duct or hepatic duct. How about C? Left hepatic duct because it's towards the pancreas. Oh, that's two C's. Wow. Okay, let's just get you guys correct. Make this D. C, right hepatic duct. D, left hepatic duct. E, bile duct or common bile duct, same thing. Bile duct is enough. And how about F? Pancreatic duct. Okay. And how about, what's left? G? Let's just call it N. I don't like G's. How about N? Gallbladder neck. Very good. And then how about G? Gallbladder. Okay, good. So I want to talk about gallstones. I think that should resolve a lot of issues. Now, gallstones. What are the types of gallstones, first of all? You see, I'm going to spend a lot of time on that, so it's high yield, because it's the cause of acute pancreatitis, it's the cause of acute cholecystitis, it's the cause of acute cholangitis, covers everything. In some cases, also cause of cancer, pancreatic cancer. Okay, what are the type of gallstones? Cholesterol stones. Anything else? Bilirubin stones, and you can have the mixture of the two. In almost all cases, 90%, 95% of all stones are what? Cholesterol containing. Could be pure cholesterol or mixed with bilirubin. Okay? Now, cholesterol stones are non-pigmented stones, right? And bilirubin is what? Pigmented stones. Good. Which means pigmented stones, pigments can be seen on X-ray. So cholesterol stone is tough to see on X-ray. You might have to use ultrasound or HEXA scan or HIDA scan. Whereas bilirubin stones could be used and seen on what? CT scan. Bilirubin stones are usually rough, dark, stone-like, but they crumble upon touch. Cholesterol stones are usually brown but hard as rock and smooth. So you should be able to differentiate. Cholesterol stone, think of gold. They're smooth, they're brown like gold, and they're hard like gold. Whereas bilirubin stones, they're soft, they're rough looking, they're dark, but they crumble upon touch. Okay, just like a sand, you know, when there's water and holding some sand, you just touch it, it crumbles. Okay, that's good. Now, cholesterol stones are common in who? In people who have hypercholesterolemia or obesity. Especially those people who have a lot of estrogen. Men or female don't matter. Okay, so people who have estrogen, they're at risk of cholesterol stones. So obviously female are more likely to have cholesterol stones. Now when we talk about bilirubin stones in anemic patients. Now, the idea here is once you have all of this, what is the big deal? Cholesterol stones, if they are just stones, it will only irritate something. Stones by themselves, if they don't cause obstruction, it will be just episodic pain. If you just think about stones, only think of episodic pain. Right upper quadrant pain, that's episodic. Comes and goes, comes and goes. No fever and no jaundice. Gallstones by themselves should only give you pain. Gallstones by themselves will give you only pain. Now, let's say if gallstones are here, they can cause cholecystitis. Cholecystitis. As soon as you say cholecystitis, now it's pain and fever. Itis leads to fever because it causes inflammation. Interleukin 1 will be released and so forth, that will cause that. If there's a stone here, same thing. Only fever and pain. Right upper quadrant pain. If you have stone here, same thing. Right upper quadrant pain and fever. If you only have stone here, same thing. As long as there's no obstruction of bile flow. As long as there's no obstruction of bile flow, there will be no jaundice. Now let's talk about what would cause jaundice. if you have a stone here, which I will label 1, position 1. If you have a stone here, or here, or here, anywhere that will lead to bile flow obstruction, you will have jaundice. Okay? But anything from cystic duct and up, no big deal. No jaundice. Left and right, you have one duct empty, one blocked, still no jaundice. Okay, so that's one thing. When you want to compare gallstones, so let's have three things. You should be able to compare three things. Just gallstones, acute cholecystitis, acute cholangitis. Look, acute cholecystitis means inflammation and infection of what? Gallbladder only. When you say angitis, it is bile ducts only. You can have a mixture of the two, that's fine. Okay. Now ducts, depending which duct, as long as it's not cystic duct and not one of the right and left hepatic duct, if it's both ducts at the same time, or common bile duct or common hepatic duct, then it will lead to jaundice. So here you have only pain. Here you have pain and fever. Here you will have pain, fever, and jaundice. Okay, assuming the blockage is in position 1, position 2, 3, or 4. But if it's position 5, 6, 7, 8, let's say 9, no jaundice. So anything that causes irritation of gallbladder will lead to what? Will lead to fever and pain. As soon as you have obstruction bile flow, it will be jaundice in addition to that. And jaundice will cause light stool, dark urine, and pruritus or irritation of the skin. Okay. Now the jaundice have to be caused by accumulation of what? Bilirubin, conjugated or unconjugated? Conjugated, because it's already been processed by the liver. Liver causes conjugation, not gallbladder. After the liver, whatever happens is conjugated. Unconjugated. In the liver is both. Excellent, good. Alright, so now I want to talk about, so that's cholecystitis, cholangitis, and gallstones. Good? So the question that usually will come is with cholecystitis, cholangitis will be based on location, anatomy. Treatment for both of them is cholangitis and cholecystitis is what? Remove the stones and use antibiotic. Remove the stones and use antibiotics. Okay? Now you can use morphine, for example, as a painkiller. Huh?
Removing the stone only by surgery.
Well, you can. It depends on the size. If it's small, if it can be passed, you can use lithotrophy, ultrasound, waves. If it's too large, then you have to do surgery. You can sometimes use medication that will dissolve the stones, like bile acid raising type of medication. That's similar to bile acid. Yeah. Okay. All right. So for cholecystitis again, acute cholecystitis, you have to use antibiotic, and you have to use something for pain killing, maybe meperidine. Okay. Out of all, because it's a severe pain, and for severe pain, for example, you should use opioid, but you don't use morphine because that will induce contraction of what? Sphincter of Oddi. Excellent, and that will cause even further symptoms. So use meperidine, which doesn't have much action on that. Good? Okay, so that's one thing. What else do I need to do? Okay. Yeah. That's good. So you know the symptoms, you know the treatment, diagnosis. Again, there's something known as ERCP. What does that stand for? Endoscopic retrograde cholangiopancreatography. It's a scope that that has to come from here and visualize the bile duct and pancreatic duct. That's why it's called retrograde, because it goes backward, and it's cold because of bile duct, pancreatography, pancreatic duct. You can visualize them. They're diagnostic. If there's a stone, you can remove it at the same time. If it's too large, maybe you have to do open surgery. Okay. So that's for this. Next thing. The best thing is, for all these cases, exercise and diet. But pain is right upper quadrant pain that radiates where?
The shoulder?
Which shoulder?
Right shoulder.
Right shoulder. right shoulder and right upper back. Right shoulder and right upper back. But you make sure that you also keep in mind that this pain will always increase with fatty food intake, because it stresses your gallbladder, and then CCK is released, it causes contraction in the gallbladder, increases pain. And the pain of cholecystitis will also increase with what? Not cholangitis, only cholecystitis. With breathing in, inspiration. What do we call that sign? Murphy's sign. Pain will increase with inspiration, because when you inspire, you contract the diaphragm, and it pushes the gallbladder and causes pain. Okay. Or if you increase intra abdominal pressure. Okay, good. So these are some things. Now, if you have gallstones here, this will cause two things: acute cholangitis, acute cholecystitis. At position what? What is this position? Let's say position 9. It will cause acute cholecystitis, acute cholangitis, and acute pancreatitis. Gallstones in the ampulla vata will cause all three things: acute cholecystitis, acute cholangitis, and acute pancreatitis. Okay. And what's the most common cause of acute cholecystitis in terms of infection? E. coli. E. coli. E. coli. Which means what? E. coli is bile resistant. Bile resistance. It cannot be killed by bile, unlike other gram-positive bacteria. Right? When we talk about, for example, strep viridans versus strep pneumonia, strep pneumonia is killed by it, but strep viridans is resistant to it. Okay. But anyhow, so E. coli. Klebsiella tuss, it's all enteric bacteria. Bacteria coming from where? From colon or intestine. Okay. Similarly, if you have a mass, which is a tumor in this area, will act the same thing. Will be the same thing. The end result is the same. We talked about acute pancreatitis already. So I just want to show you, like how. Okay, what else do I need to do? Sometimes you can have pancreas in fetuses. Pancreas will have anterior bud and then posterior bud. Yes, these are supposed to rotate and fuse together, but if the anterior bud loops around and completely and will obstruct the duodenum. Okay, it now acts just like duodenal atresia, or what's the next one? We just talked about it. Pyloric stenosis. Yeah. But in this case, most of the time the duct is, the obstruction is before, in rare cases before, in majority of cases it's after the duct, so you'll have bilious vomiting as well. That will help you understand the difference. What else? We talked about cancer and pancreas, we talked about acute pancreatitis, chronic pancreatitis. Let's say you have pancreatic cyst. Pancreatic cyst will be simply a complication of acute pancreatitis. When that happens, it can become infectious and it will become pancreatic abscess. You will have severe, spiky fever and epigastric pain. And this pain upon touch is tremendous, because the abscess is like a ball full of fluid and infectious agent. When you touch it, it hurts even more. So there is tenderness, there's pain, and there's high fever. In those cases, usually a physician confuses this with a mass, solid mass. So you will have to do ultrasound. Ultrasound differentiates between solid and cystic masses. And in this case, you will see fluid-filled mass that the position of water, whatever fluid, changes with your position. Okay, for example, if this is a round mass, water will usually be this shape. But if you rotate, this curve shape will still stay the same. For example, let me show you. Whoa, okay, what happened? Can't do that anymore? For some reason I can't use that tool anymore. What I'm saying is, if you change this should become this way, like the curve. Yeah, but it doesn't change, so that means it's an abscess. Okay, the fluid will not shift, the position of fluid. I can show you in a picture, but maybe I'll show you tomorrow. If the tumor is in the tail of the pancreas, think of renal failure or splenic hemorrhage. Think of those things. If the tumor is posterior pancreas, think of maybe peritoneal erosion. If the tumor is anterior pancreas, think of stomach obstruction or stomach perforation or something like that, because stomach is right in front of the pancreas, slightly superior. There's one more thing in pancreas that's very, very important. You see this area, the neck area? You will have here superior mesenteric artery and superior mesenteric vein going here. So technically the pancreas, the neck goes like this right at it. So if you have a mass in this area, it will cause obstruction of one of these vessels, and that will cause edema in the lower extremities and the abdomen. Okay? So look for those things. I don't think there's anything else when it comes to pancreas. If you do want to study, out of all of them, make sure you study chronic pancreatitis and acute cholecystitis. Those two are very high yield, but you have to know the anatomy behind it. Liver, I will do tomorrow. Small intestine, if I reach colon, we'll do tomorrow. Let's do some questions. Okay.